Hello everybody, and welcome to the Kirby Institute's weekly seminar series. My name is Andrew Grulich and I'm the head of the HIV Epidemiology and Prevention program here at the Kirby Institute. I'd like to start with acknowledging the traditional custodians of the various lands we're meeting on today, and for me that's the Bedegal people of the Eora Nation. Some housekeeping to start with. Today's talk takes the format of a 30-minute talk followed by a panel discussion. We have a panel here, but we'd also really welcome your questions. You do have a Q&A field on the interface. That's the bubbles up towards the top right of the screen that you're looking at. If you press on those, it will open up the Q&A, and you can ask your questions at any time through the talk today. If you could remember to write your name, that would be helpful for us. And when it comes to the panel, if you have a question for a particular panel member, then please note that in your question. So today's presentation is on a project called the GAPS project. I think everybody should be aware of the enormous advances we've had in HIV prevention in Australia over the last decade or more. And this project really delves further into where we're doing better and where there are some gaps that need further attention. And the point that I think is going to be made today is that we need to address these gaps if we're serious about HIV elimination. The presentation today is by the leader of the GAPS project, Dr. Ben Bavinton. Ben has worked in the field of HIV prevention and research for 15 years in Australia and internationally. He's a research fellow at the Kirby Institute, focusing on biomedical, behavioural and epidemiological aspects of HIV prevention in Australia and in the Asia Pacific region. Please welcome Ben.
Great, thanks very much, Andrew. So as Andrew just said, today's seminar will be on the GAPS project, which is all about identifying gaps in HIV prevention amongst gay, bisexual and other men who have sex with men in Australia. This is really, I suppose, the launch of the GAPS project report, excuse me, which is now available online at this link here at the Kirby Institute website, or you can just Google Kirby GAPS report to be able to download the entire thing. It's quite a long report, and so I'll just be summarising some of the findings today. To start, I just want to acknowledge my co-authors and investigators, and particularly Ithandi Ong, who was the person who actually ran this project from the very beginning. She sort of coordinated all the data sets, she did all the data analysis, and she wrote the report. So thanks very much, Ithandi. And I'd also like to thank the Australian Government Department of Health for funding this work, as well as a very large number of contributors who contributed in various ways to the sort of development and also the finalisation of this report. So in terms of background, we all know Australia has the national goal to virtually eliminate HIV transmission, and new advances in biomedical prevention, in combination with those existing behavioural approaches that we've already had for a long time, suggest that this goal is achievable. And globally and in Australia, there's an increasing focus on inequalities in HIV, and this is well exemplified by this global UNAIDS strategy that was released just a few weeks ago, which is all really about ending inequalities around the world in HIV and HIV prevention. Within the gay, bisexual and other men who have sex with men population, there is a concern that some groups are being left behind, or at least not experiencing the same levels of HIV prevention success as other groups. And so to achieve the elimination of HIV transmission in Australia, as Andrew has just said, we need to identify and address gaps in the HIV prevention response. And this project was just trying to do a little bit of that. So really the overall aim is to determine the differences in trends in HIV diagnoses, testing, treatment and prevention outcomes across subgroups of GBMSM in Australia. This project is not aiming to be exhaustive, so we couldn't examine every single gap in the HIV prevention response, but our goal was just to use 3 existing data sources to explore gaps in a set of important HIV prevention related indicators. So in terms of our methods, our 3 data sources that I just mentioned, we have firstly the National HIV Registry, which is coordinated by the Kirby Institute and brings together all the HIV notifications data nationally. We have the Gay Community Periodic Surveys, or GCPS, which is coordinated by the Centre for Social Research in Health in partnership with the Kirby Institute. This is Australia's primary HIV behavioural surveillance system for gay and bisexual men. and also the Access Sentinel Surveillance System for STIs and BBVs. This is jointly coordinated by the Kirby Institute and Burnett Institute in Melbourne. This extracts data from clinics all around the country, data that's just routinely collected through medical records. The time frame for most of the analyses that we looked at this in report was 2009 to 2018. Some analyses had to be a little bit shorter than that just because of the availability of when the indicators started being collected. But for the most part, it is for that 10-year period. And we focused on 4 main areas of these sort of HIV and HIV prevention outcomes. So starting with HIV diagnoses, we looked at these overall within the newly acquired. So this is where we have some evidence that the infection occurred within the last 12 months. And also late HIV diagnosis that has a technical definition that you can look up in the report, but I won't say now. We also looked at HIV testing, HIV treatment and viral suppression amongst HIV positive GBMSM, and also HIV prevention. And this covered things like PrEP awareness, PrEP use, sexual behaviour, and overall prevention coverage. The focus of the report is really on 3 main stratifications that sort of all the way through the report. Starting with region of birth, we sometimes present this as Australian born versus overseas born, and sometimes we present it by breaking it down into the 6 categories you can see there on the screen. We also had location of residence. So if anyone who came to the seminar by Philip Keane a few weeks ago would have heard about this method that we've used to estimate the proportion of gay men living in every Australian postcode around the country. So what we've classified our postcodes a little bit differently in this project than Philip's, because it's a national project and it's not just New South Wales, which means that you have to think a little bit differently about the gay postcodes within each city. So the way that we've defined gay postcodes is gay capital city postcodes, where this is where more than 5% of the resident men identify as gay. Then we've got the other capital city postcodes and then regional, rural or remote postcodes. We also looked at age. There's a few different ways we've broken down age throughout the data I'm going to show you today, but the main way is, I suppose, using these 4 categories on the screen now. Sometimes we look at just under 25s and 26s and over. Sometimes we break it slightly differently depending on when we look at the data, what groups are sort of showing differences or divergences. So that will get explained as we go through this presentation. Now, the actual report is structured around the outcomes. So it would start with a chapter on HIV diagnoses, which uses National HIV Registry data, and then it breaks down the diagnoses into those 3 stratifications. Then it moves on to a chapter on HIV testing, and it does the same thing. It takes data from the GCPS and Access, and then breaks it down by the stratifications. Now, as you can imagine, this has led to pretty much hundreds of graphs throughout the report. It's a very dense report, because we went through very systematically and very comprehensively in the report. So we basically just reported but every stratification for every indicator that we were looking at, almost. So that means that there's far too many graphs to look at in this presentation today. So what I'll be doing today is focusing on the stratifications, region of birth, location of residence, and age, and then really pulling out the primary findings or the most interesting findings from each one of those stratifications. I will also just say that there were other stratifications that we did consider and that we wish we could have done more on. Aboriginal and Torres Strait Islander status, for example, is a really good example. There's already a report that's produced every year on that population, so we didn't make that a focus of this report, but also an issue was that the numbers were just so low, so it was hard to actually do much in terms of stratifying. Another important area is cultural and linguistic diversity or ethnicity and cultural background, that sort of kind of area. Unfortunately, in many of the data sources, this isn't really very well collected, so I'll talk about that a little bit later as well, which means that we really aren't able to do stratifying on that basis. So we really just chose these 3 because they were the most reliable over the period that we were looking at. So starting with region of birth. So this is the HIV diagnoses by just Australian born and overseas born gay, bisexual and other men who have sex with men from 2009 to 2018. So firstly, you can see that there's been a sustained decline in diagnoses in Australian-born men since 2016, and this is a 33% decline. The decline kind of started a little bit earlier than that. You can see it sort of starts back in sort of 2014, but it really accelerated in 2016 with the advent of widespread access to PrEP through the prevention trials that were happening. By contrast, we've seen a 65% increase in HIV diagnoses in overseas-born men from 2019 to 2015, and then we sort of see this stability thereafter. So in terms of those overseas-born men, this is just breaking down into that six region of birth categorization I showed you earlier. And what this is really showing is that diagnoses in Asian-born men increased from 32% in 2009 up to 54% in 2018. So now it makes up Asian-born men make up the majority of these overseas-born diagnoses. We've also seen some increases in the Latin American men, and we've seen these decreases in the high-income English-speaking countries, such as the USA, UK, Ireland, New Zealand, and also in men from Europe. This graph shows newly acquired HIV diagnoses. So just as a reminder, this is where we have some evidence in the data set that these infections happened within the last 12 months. And this is quite important because this is a better indicator of recent, I suppose, HIV incidence. Because when you look at overall diagnoses, there may be quite a lot of people in the mix there who were actually infected with HIV many years earlier, and it doesn't really tell us about the effectiveness of our current prevention efforts. So this is quite an important indicator, and we're actually focusing more and more on this indicator. And what you can see here is that there's been recent declines in both overseas-born and Australian-born men in these newly acquired diagnoses. So that's really great news. By contrast, we're seeing something very different in the late HIV diagnoses by region of birth. So overseas-born men now have had a sustained increase in the number of late diagnoses every year, going back quite a few years, really back to about 2013. In 2018, 55% of all of the late diagnoses were among overseas-born men, and then of those, 2/3 were of Asian-born men. And then amongst these late diagnoses, we wanted to look at how long these overseas-born men had been living in Australia. And you can see that we've broken it down by 3 years or less, 3 to 5 years, 5 years or more, or unknown. And you can see there that the proportion of unknown is getting smaller each year, so that's great. So that means the data quality is improving, so we have more confidence. And what we can see here is that in the 2018, there's been an increasing proportion of late diagnoses among overseas-born men that have lived in Australia for less than 3 years. So the lack of overall decline in HIV diagnoses in overseas-born men appears to be driven by non-early and late diagnoses. And it's likely that most of these men arrived in Australia with HIV, suggesting that they may not be getting tested for HIV until some time after their arrival. So reducing barriers to HIV testing and increased efforts to link these newly arrived men to testing are key priorities. In terms of testing, treatment and prevention, our other data sources, the GCPS and Access, typically don't reveal differences between Australian-born men and overseas-born men. Well, not many. Some more recent work I've been doing has looked at those really newly arrived men, and we are starting to now see some differences in the GCPS. But back at this point, where we didn't have that arrival data, we really didn't see much differentiation. So what that means is that when you look at all the graphs, overseas-born men and Australian-born men appear to have similar rates of testing, treatment as prevention. But given those big differences in HIV diagnoses data, why might this be? And some key reasons could be that the GCPS primarily recruits men who are connected to gay community, and Access includes men who are by definition connected to clinical care, at least to some extent, because to get into the Access dataset, you have to have attended a clinic. So we're not able to draw conclusions about the men who are not connected to gay community and/or to clinics. We don't really know how many of these men there are. We don't really know how impacted they are by HIV, and we don't know what extent region of birth interacts with connection to gay community and to clinics. We don't really know what sort of role this group of perhaps this disconnected men plays in the overall HIV epidemic. We have qualitative data that give us hints, but we don't really have any way of finding out how big this group actually is and the impact they're having on the epidemic. The one important implication is that once overseas-born men are connected to gay community and/or to clinical care, the disparities do tend to lessen or to disappear. And this is supported by other data sets, such as the AHOD data sets, which is HIV positive men in Australia, really again showing that once they're connected to care, there is no difference between HIV treatment and viral load suppression. Moving on to location of residence. So this is where we have our 3 categories, plus there's a line for missing or unknown there. So the gay capital cities, other capital cities, and then regional, rural or remote. So since 2012, there's been a 37% decline in HIV diagnoses in men living in the gay capital city postcodes. In other capital city postcodes, there was an increase until 2016, and then we saw that relatively sharp decline there, probably due to PrEP. And then by contrast, there's been a 60% increase from 2009 to 2018 in regional, rural or remote postcodes. We see similar patterns for those newly acquired HIV diagnoses. So there was an earlier and there's been a sustained decline in gay capital city postcodes. And this is quite amazing to see that there's been this 72% reduction in newly acquired HIV diagnoses in these inner city postcodes from 2012 to 2018. There has been a later decline in these newly acquired HIV diagnoses in the other capital cities, which is in the red. And there's been no decline or perhaps even a bit of an increase over the 10 years in the regional, rural or remote postcodes. This is just a way of cross-tabulating that issue of overseas born versus Australian born, and then the gay postcodes where it's more than 5% gay men versus the non-gay postcodes where it's less than 5% gay men. And what this is just overall diagnoses, and then also, which is in the red on the lines, and then the purple is the newly acquired diagnoses. And you can see here there's really strikingly different patterns. So you see in the Australian-born gay postcodes, it's been a pretty much sustained downward trend for the last 10 years, really. Whereas in overseas-born non-gay postcodes, it's pretty much flat. In the overseas-born in the gay inner-city postcodes, it sort of went up, it plateaued, and then it went down. And then in overseas-born non-gay postcodes, it's really seen a sustained increase. So this is quite interesting. It means that there's some kind of interaction going on between your country of birth and then where you live. And that might give some hints about how we need to target future interventions. In terms of HIV testing, we've seen over many years that there's this difference between the 3 postcode groupings, whereby the gay capital city postcodes have the highest rates of testing in the previous 12 months. The other capital city postcodes are in the middle, and then the lowest rate is in the regional, rural or remote. Should be said the difference isn't huge, but it is still a difference. And this gap actually does persist. I'm not showing the data, but it persists even when we restrict these, this indicator to higher risk men, which in the case of testing is considered to be condomless sex, group sex, more than 10 sex partners, or drug use for sex in the last 6 months. If we look at PrEP uptake by location of residence, firstly, I'll just say there's no difference in PrEP awareness, at least in the gay community periodic surveys. But if we look at PrEP use, we can see that there's been increases in both the gay suburbs and the non-gay suburbs in those people who are having condomless anal intercourse with casual partners, which is who we consider to be the high risk men who are suitable for PrEP. But you can very much see here that there is a difference in the rate of that increase, and there's a disparity in the proportion. And just to remind everybody that the national target in the HIV strategy is 75% of high-risk men to be on PrEP. And as I said, we just use as a shorthand way any condomless intercourse in the last 6 months with casual partners as being an indicator for high risk for PrEP. And finally, in this section, prevention coverage by location of residence. So I just need to explain this a little bit. Some of you might be familiar with Professor Martin Holt's famous rainbow slide, which really breaks down men who are having casual sex into various categories of their kind of prevention use or non-use. This is a slightly adapted form of that. So we've got 4 categories. The light blue is no men who have had casual sex in the last 6 months but had no anal intercourse. The next group is those who had casual partners but used condoms consistently. The yellow group is those who had condomless anal intercourse with casual partners that was protected by biomedical prevention, that being PrEP or TASP. And the top group is those who had condomless anal intercourse with casual partners that was unprotected by biomedical prevention. These are the ones that are sort of susceptible to HIV infection, or in a very, very tiny sliver of men, HIV positive people with detectable viral load who do say that they've had condomless sex in the last 6 months. So this concept of prevention coverage is something that we've been working on the last couple of years in the GCPS team. And we define this as among men having casual sex, the proportion not having anal sex, consistently using condoms, or using PrEP or TASP. So it's basically anybody using any effective form of prevention. And due to the differences in PrEP use, we do see a difference in these postcode categories. So prevention coverage was higher at 74% in the gay postcodes than in the non-gay postcodes at 69%. The difference isn't huge, but it is still a difference. So while geographic differences in diagnoses, testing and PrEP are clear, we don't really have a good understanding of what drives them. We have a lot of hypotheses, but we don't really have much proof, or we haven't really untangled this very well yet. Some of the hypotheses include things like connection to gay communities, structural stigma, socioeconomic factors, access to nearby and appropriate services, or potentially differential exposure to HIV education. And many more hypotheses have been floated. So we do need more research to try to untangle this a little bit more, and then we'll need targeted interventions. And as I said before, that cross-tabulation of country of birth and location of residence may be quite important there as we're planning interventions. The last point I'll make here is that we might be on our way to micro-elimination of HIV transmission in the inner city, highly concentrated gay suburbs, particularly among Australian-born gay men. But it's really important not to consider the job done in these areas, because if we start to disinvest in the successful approaches that have been done in those areas and just pivot all of our work to these kind of the disparities that we're seeing emerge, we may see a resurgence. So it's quite important here to note that we do need to keep all the work going, but then we also need to do some new work that targets these inequalities a little bit better. So moving on to age. In this graph here, we've got the 4 age groups, and it's just the overall HIV diagnoses by age group for the last, that 10-year period. So you can see that there was a 41% decline from 2009 to 2018 in that middle age group of 36 to 55. Now, the reason we didn't divide that age group up into sort of 10-year slots or divide it up in any other way is just because when we looked at the data for those 3 groups, the patterns were just so similar, it just made sense to group those together. So you've got quite a large age span there from 36 to 55. But we did see no declines in the other age groups overall, although we did see some declines since 2016 in men under 36. So that's the 2 groups of 26 to 35 in the kind of darker green, and then the 25 and unders in the purple, which you can see it's just like starting to see that come down. But really no change in those aged 56 years and over. Late diagnosis has also steadily increased since 2014 in that 26 to 35 years age group. And I'm not showing the data there, but it just sort of has steadily gone up over that time. So a bit of an investigation into that is needed too. Moving on from diagnoses into the other indicators, we start with HIV testing. So you can see here that we've seen an increase in HIV testing in the last 12 months in all age groups. But higher risk men over 56% years are somewhat less likely to be tested. So this graph here is restricted just to those men who have condom or sex, group sex, more than 10 sex partners, or drug use for sex in the last 6 months. So really that's all there is to say about that, but just to say because all of these men really should be getting tested more frequently than once a year or not at all in the last year, that we would like to see that gap start to close. Moving on to HIV treatment by age group. Now, this is one of the only indicators that actually shows much difference in the HIV treatment and viral suppression area. Pretty much everything else, such as country of birth and location of residence, we didn't really see any differences in the HIV treatment and viral suppression area. So you can see here from the access data that by 2018, more than 90% of all the groups were taking HIV treatment. And the biggest increase has been in the younger men. So this is because the guidelines really changed in 2015, really recommending that everybody go into treatment immediately, regardless of CD4 count. And prior to that, I think a lot of clinicians and young men themselves had sort of decided to hold off on treatment until they were sure they really needed it. But that's really escalated over the last few years, and we've seen that really pleasing increase in their uptake of HIV treatment among the younger men. The younger men do still have a slightly lower treatment uptake, and we're not really sure what's behind that. We need some more investigation there. And I haven't shown the data here, but they also do have slightly lower viral load suppression, even in those men who are on treatment. So that's something that's not very good to see, because in everybody who's on treatment, you would be hoping for these really high levels of viral suppression. So we do, even though it's quite a small difference between the age groups, I personally think we do still need to do a little bit of an investigation to understand why that discrepancy is happening, even though it is small. In terms of PrEP use by age, this is where we really see some quite marked differences between the, here it's 3 age groups. So by 2018, only 29% of men aged less than 26 years who reported condomless intercourse with casual partners were taking PrEP in the last 6 months. And that's the yellow line there, so it's the lowest line. And you can see there that the men 56 years and older are only just slightly above that. And then the group that has the highest use of PrEP is that 26 to 55. So this is even a larger age range there. So clearly we have some work to do here, because all of the men that's included on this graph are people who are having condomless anal intersex in the last 6 months, which means that these men are definitely suitable for PrEP. And so the fact that there's such disparity in the uptake suggests various things that might be going on, such as access concerns or maybe PrEP literacy concerns, knowledge, various other things. As before, awareness is not the problem, because we saw across the entire GAPS project report that there were no differences in PrEP awareness across any of the stratifications, pretty much. So also important to note here that in all age groups, at least in 2018, there was still quite a long way to go to the target of 75% in the national strategy. And finally, in this age section, we'll look at prevention coverage. And so this is an area, again, where we see quite striking differences. So here, we've just divided things into 25 years and under and 6 years and over, sorry. And we can see that prevention coverage was only 54% in men 25 years and younger, compared to 74% in men aged 26 or older. And really, we can see from the 2 graphs that that's primarily driven by the lower uptake of biomedical prevention, which in turn is driven by the lower uptake of PrEP in those younger men. Condom use is slightly higher in those younger men, but it's not massively high. It's only 29% of those who are consistently using condoms versus 26 in the over 26s. So in terms of age, just to sum up, the biggest declines and best access to HIV testing, treatment and prevention are in the age group 36 to 55 years. Further research is needed to explore this kind of discrepancy in HIV treatment in the younger men, and also HIV treatment, HIV testing and PrEP in some of the younger men as well. But it is important to note here that we may have some similar problems in these data sources as seen with the overseas born men that I mentioned before, in that we only have access to those already somewhat connected to the gay community or to clinics. So for example, there might be a group of younger men in particular and older men who aren't as connected to the gay community that may not be showing up, or to clinics, sorry, that may not be showing up so well in these data sources. But again, it's the same problem as I said before, that it's quite difficult to assess this. And there are also potential confounding or interaction effects between age and location of residence. For example, younger men may be more likely to be living with their parents in the places that they grew up, which may be more suburban and regional in nature. And older men may have settled in the sort of inner city gay suburbs of the capital cities earlier. And also there's an affordability element to that as well. And there might also be interaction effects there with age and region of birth. So of course we know that before COVID anyway, there's a very large number of international students in Australia. And on average, international students do tend to be on the younger side. So it may be that some of these patterns that we're seeing in the age data are driven by other things, such as location of residence and by region of birth. So just moving into this concluding section. In terms of an overall summary, there's been recent declines in HIV diagnoses in gay, bisexual and other men who have sex with men, most likely driven by the rapid, large-scale PrEP uptake since 2016, but it has to be recognised that this was built on a foundation of much longer-term increases in HIV testing and treatment as well. We did achieve the 90-90-90 targets, I think it was in about 2017, and then really PrEP was really took off in 2017 and 18, and particularly in 2018 after it was listed on the PBS. There are a diversity of trends that exist within these overall numbers, which I've shown some of those trends to you today. And disparities have emerged among subgroups of MSM. And this includes the overseas born, the younger men, and sometimes the older men, and also the suburban and regional men. These disparities are also being seen in many other similar countries as well. So if you look at the UK, and particularly in London, they see similar things in the sense that you have Black and minority ethnic men who are seeing less impact on diagnoses in that group compared to the white men. In the US, you absolutely see ethnic differences, particularly with Black men who have sex with men, and there being quite differential rates there. In France, I've read some literature showing that there's those issues of location that are definitely happening in France, where the sort of outer suburban and regional areas are not seeing the same kinds of impacts as they're seeing in the inner cities. And age is a really big issue in our region. So all through the Asia region, there's several countries where the HIV epidemics are really concentrated within very young gay and bisexual men. So this is sort of 15 to 18 years old. The countries like the Philippines, Indonesia, and Thailand are in this situation where these very young men are disproportionately affected by HIV in that region. So just trying to draw these groups together a little bit to help us think about a way forward, I suppose. So there are some things that these groups may have in common, more than some of the other groups that are doing better in terms of the HIV prevention success. For example, some of these things may be heightened experiences of stigma or fears of anticipated stigma. So you can imagine how this might play out for an overseas born person coming from a country where HIV is highly stigmatized, or where being gay or bisexual is highly stigmatized. And they come to a place like Australia, they're not so aware of our cultural norms here, and they're afraid of potentially going to a hospital or to a doctor admitting that they're gay. Some of these men might have not even come out to themselves yet, even before they arrive to Australia, and we do see that in qualitative research. In younger men, it may be that they're still going through their own sort of coming out and sexual identity processes. They're trying to figure out what works for them in terms of sexual behaviour and prevention. And they may experience or have these fears of stigma in a different way from older men. And also in suburban and regional locations, we have some evidence that the stigma towards being gay is higher in these locations. We saw that with the Marriage Equality Postal Survey, where there was that sort of donut hole in the middle of Sydney that had very high rates of no votes. And those people living in those suburbs may actually feel this on a day-to-day basis. These groups also may have in common a little bit less social connection to inner city gay communities. So with overseas born men, this may be a linguistic issue. This may be, again, those issues around stigma. For younger men, it might be they're living at home and they're far away. Suburban and regional men, just by the fact that they don't live in those inner city gay communities, it might mean they're slightly less connected. Of course, you can definitely have online connections that don't rely on geography. These groups may also have potentially lower health, sexual health, and HIV literacy. Again, reinforcing the same sorts of issues that I've already talked about. It may be that they're less exposed to HIV prevention education if they live in a particular area. It may be that younger men have had not very good sexuality education and sex education in schools, and they're sort of just coming onto the scene without a lot of knowledge. It may be in the overseas born men that they're coming from countries that really don't have much education at all in the way of HIV prevention, and certainly don't talk about sexuality very openly. They may also have less access to culturally appropriate, affordable, gay and bisexual friendly services. So here there's a couple of different things in this sentence. So culturally appropriate, it might be that people from certain backgrounds do or don't want to see clinicians from their own background. It might be there's a linguistic issue there, a language barrier issue where most services are offered in English, most websites are in English. Affordability is an issue, even though PrEP is now quite affordable on the PBS and it's even cheaper if you order it online. We do hear from qualitative evidence that this is actually still too much for some people to be able to afford, and perhaps that's where on-demand PrEP can play a role. And the access to gay and bisexual friendly services is definitely an issue in terms of location, where most of those services are located in inner city suburbs, and there's not very many really sort of openly advertised gay and bisexual friendly services out in the regions and the suburbs. And they may also have the commonality of potentially lower socioeconomic resources. Although again, we don't really know how much any of these factors impact on the HIV prevention. So just my second last slide here, just some considerations about the data. So convenience samples such as the GCPS and the clinical data from Access will always have potential problems with representativeness. And these problems are actually difficult to assess because you don't actually have an easy way to find out how big this population may be that potentially exists out beyond the community or the clinics. So compared to who is getting diagnosed, our data from the other sources typically do underrepresent Asian and Latin American men. They do underrepresent younger men, and they slightly underrepresent men living in regional, rural or remote postcodes. I just want to say here as well that the GB-MSM category that I'm using throughout this report and presentation does conflate sexual behaviour and identity, and different data sources include or focus on subgroups within this category in various ways. So the GCPS, for example, is really almost completely gay and bisexual identified men. So these are men who actually hold that identity. Whereas the HIV notifications data and access really aren't interested in identity and really only focus on behaviour. It's also important to note that those identified men and sort of less or non-identified men are going to have different prevention needs, different access to community and education. And so we need to think about that in the way that we respond. This report and project really did focus completely on gay, bisexual and other men who have sex with men, although it was in some ways inclusive of trans MSM. But it really wasn't able to include trans and gender diverse people, unfortunately. These people are not well identified in the data sources, and the data are really inconsistently collected. So this is an important thing that we need to focus on going forward. And as I mentioned right at the top of the presentation, that cultural and linguistic diversity, aside from country of birth, is another thing that's not very well collected. So we do collect that in the GCPS data, but that data is not in the HIV notifications data or in access. So one implication for this, for example, is that we actually don't know the impact of cultural and linguistic diversity on the overall HIV epidemic, particularly among Australian-born MSM. So it may actually be the case that there's more or less infections in cold people, so cultural and linguistic diverse people, within the Australian-born men who have sex with men, but we aren't actually able to crunch those data. So just finally, implications for policy and programming. Here's just a few. So certainly we need faster linkage to HIV testing for newly arrived men. We need culturally sensitive or specific services and health promotion for these overseas born men and linguistically and culturally diverse men. We need better access to gay-friendly HIV testing and PrEP services that are outside of the inner city suburbs of the capital cities. We need targeted approaches towards HIV testing, PrEP and treatment for younger men, and targeted HIV testing and PrEP efforts in older men. We need greater inclusion of overseas born and culturally diverse men, non-gay identifying men, younger men, and men living outside of the inner city gay areas in HIV behavioural surveillance and prevention research. And I'm pleased to be able to say that the GCPS has recently been awarded some funding from the NHMRC, which is going to allow us over the next 5 years to experiment with some different ways of broadening the reach of those surveys. And at the end of the 5 years, we will evaluate those and then put those into practice, at least the ones that work. And of course, we need continued efforts to increase PrEP uptake, rapid HIV treatment initiation, and HIV testing across all GBS-MSM subgroups, including, as I said earlier, that sustained funding for existing approaches and further funding for the new approaches. So I will leave it there. Thank you very much, and I look forward to the panel presentation. Thank you.
Thank you for that terrific presentation highlighting quite incredible diversity in the epidemic in Australia as we start to see successes related to our new prevention technologies. We are going to have a brief panel conversation now, but I really do encourage you to ask those questions. We've got plenty of questions coming in, which is great. You can, if you see a question there which you like, you can upvote it. We may not get time for all questions, so do use the upvote question if you want to see a question get addressed. So, but before we go to the questions, I'd like to briefly go to our panel. We've got, firstly, we've got Dr. Skye McGregor, who's the head of Surveillance Innovation Group at the Kirby Institute. We have Darryl O'Donnell, who's the CEO of the Australian Federation of AIDS Organisation and an adjunct professor here at the Kirby. And we have Daniel Coase from the Federation of Ethnic Community Councils of Australia. And Daniel, I might start with you, if I may, just to ask you to reflect on what you've seen and how you could see your organisation responding to the sort of trends we're seeing here in culturally diverse populations.
Oh, thanks, Andrew. First off the rank. Look, this report is fascinating, and FECO, just briefly, is the peak multicultural organisation in Australia with member organisations in states and territories and regions. And we find this particularly interesting, and the fact that you have put so much in the centre the issue about cultural ethnic diversity and what you're doing, because we're involved in a number of different projects in the health sphere from a CAL perspective, and the thing we're constantly finding is a complete lack of consistent data. There is no national data around cancer. There is no national data around opioid use, whatever it is we're working on. So the fact that you've identified that and have attempted to use country of birth and talking about regions is really interesting. Ben, you said you've mentioned that the most common indicator is country of birth and the conclusions that can be drawn by that, and of course that's really problematic. It's the most most continuously used indicator, but of course we all understand that it excludes people often in data sets if you were born in the main English-speaking countries, what you call the high-income countries. It doesn't acknowledge diversity within a particular country. Just think of Singapore with ethnic Chinese, ethnic Indian, ethnic Malay, for example. It doesn't capture refugees who might have been born in a completely different country. It doesn't, and as you pointed out too, you need to do a lot more work in terms of working around cultural diversity within the Australian born. I mean, there are approximately 1.4 million people who have English as their spoken language, were born in Australia, but have at least one or both parents born overseas. And then the issue around the aggregating it up into geographic regions, I mean, where is the actual most useful level of that grouping? So if we have a broad grouping like Asia, it's countries and cultures as different as China, the Koreas, Georgia, in terms of that. So it's kind of, there's a whole host of decisions there about what you've chosen to do with that, but it's great to see it. We've also seen it in COVID. I think there are interesting parallels between COVID and what happened with HIV. So only late last year was a National Advisory Group on COVID established after our advocacy. It's now been engaging on communicating with affected communities beyond using Google Translate. We're leading engagement with CAL communities on the vaccine rollout. And interestingly, we've actually managed to achieve a policy decision to add country of birth and a language indicator to the National Notifiable Diseases Surveillance System. I'm not sure whether that'll include HIV. Country of birth, as I say, is not adequate in many ways, but it's what we have at the moment. The policy decision's been taken, but the implementation has been problematic in terms of how it's actually rolling out. So, fabulous report, very interesting in all sorts of ways. The issue about increasing diagnosis in non-gay postcodes. I mean, is there a question there about where could the infection have occurred? For me,
sure there is, Daniel. Daniel, okay. Just for time, we might need to pass on for that. Okay. Thank you very much. And I just want to give our other panelists a quick chance, but thank you for those comments. Perhaps next we'll throw to Darryl O'Donnell. In your role in your leadership role in Australia's peak body of community organisations working in HIV, it'd be lovely to hear your comments.
Thanks, Andrew, and Ben, for the opportunity to speak. I think the first observation for me is how lucky are we to have such astonishingly good data. So even though this report is fundamentally about what are the gaps, what's missing, in looking at what's missing, it also orients to what fantastic coverage we have on so many of the key critical points of data if we're to achieve the virtual elimination of HIV, and what an exciting conversation that is. Really, I just want to make two brief comments to lead into the Q&A. One is about the importance of strategic research. So the three data sources used for this GAPS report are fundamentally or principally funded as strategic research priorities. That is, they're commissioned by government because government recognises these research pieces, the Gay Community Periodic Survey, the Access Project, the HIV Registry, that these are critical public health, public policy priorities, and that they must be funded. So they're not left to the NHMRC, to the MRFF, to the ARC to consider for funding. They're actually priorities of government. And I want to make that observation because it's just so important for all of us to be aware that strategic research will continue to be vital while we're working towards virtual elimination, and we should acknowledge the long-standing investment of the Department of Health in strategic research and encourage and advocate for the continuation of a strong strategic research program. The second point I want to make was really Just to zero in on, I think when we look at the gaps, it can be very, very overwhelming when we think about, gosh, we're already at capacity, and what this reveals is so much more for us to do if we're to achieve virtual elimination. I want to be a bit provocative and say that I'm increasingly of the view that, yes, we must get to all of it. All of it matters if we're to virtually eliminate HIV, but I really want to zero in on one aspect of it, and that is testing. Testing, and particularly testing to reduce the number of cases of undiagnosed HIV. So we've seen in this data that we have basically no change over a decade in the number of cases of late diagnosis among gay and bisexual and other MSM. That's actually really concerning. We are not going to get to virtual elimination, or we have a significant proportion of gay and bisexual and other men who have sex with men being diagnosed late with HIV. What's all this about? Well, we actually know the task of testing. We know about making testing more convenient. We know about making it more accessible. I just want to slightly problematize some of the assumptions on which that's based. It's very much based on I'm a gay man who is very active in my own healthcare. I'm going to walk into a GP. I'm going to be confident to say I need a HIV test, and want to suggest that actually part of our challenge with driving down undiagnosed HIV is to actually be more accepting that HIV salience isn't high for all gay and bisexual and MSM, even among high risk gay and bisexual and other MSM. There may not be a strong sense that this is important for me, that I need to be testing regularly, yearly, more than yearly. And I think what we need to be doing is starting a different kind of conversation about normalising HIV testing, making sure that clinicians are routinely considering and offering and ensuring and facilitating that gay and bisexual and other men who have sex with men are being tested frequently. And making that more possible, reducing the barriers to testing and increasing the confidence and the processes, the clinical processes that allow for very, very frequent testing of that group.
Fantastic, Darryl. Thank you for that. And yeah, you've picked us up on the one of the 90s that we're not doing quite so well on. Australia's doing fantastically on the treatment and undetectable viral load 90s, and testing is the one where we need to do some catch up, most particularly if we're going to reach the 95 level, which is UNAIDS goal for 2025. Okay, I might now throw to Dr. Skye McGregor, who leads a bunch of boffins working in surveillance at the Kirby, and ask for her boffin responses on whether she has any, as a surveillance expert, if she has any reflections on the data we've seen today.
Gosh, Andrew, that's a bit of pressure there. But first, just to reflect and say, Ben and Nathaniel, such a huge amount of work has gone into this. These reports are not fast or quick to pull together. And I think the important thing is, if you just look at the national figures, you can see that there's been a decline in the proportion of notifications attributed to male sexual contact, and heterosexual make up a larger proportion. But what your report really shows is it creates some visibility for the inequality within that group. If we just look at, actually, it's really easy to say, yes, we're making great progress, but we can see that there are certainly disparities in there, and that there's a lot of work to be done. I agree with Darryl that we have amazing data, but I also think that we can improve our data collection. I think we're at a point where we need to have greater data granularity to enable us to explore some of these areas in more detail. And coming back to your point about testing, Darryl, I think there are limitations in the data sets that we have available at the moment, Ben. You've highlighted that in there. I think we really do need better testing data, and as I'm sure many of you know, we've had fantastic COVID testing data, and I think now is the time to push for better national HIV testing data to really see what's happening. And if we are pushing for testing everywhere, which I think is a great thing to advocate for, we need to understand where those gaps still are outside of those gay connected populations and those clinic connected people. But also reflecting on your comments, Daniel, and we've had conversations about this already, that unfortunately the data that we collect that are around culturally and linguistically diverse populations are inherently limited, and that country of birth, and you and I have spoken about looking also at people who are born in Australia but their parents are overseas. We really have no way of capturing that at the moment. So I think from a surveillance perspective, what it highlights to me is there's still a lot of progress to be made in understanding where gaps are and where the most attention needs to be. And I think that's where working together with particularly our community partners in understanding what's data acceptable to collect, what data are acceptable to present, and where the strongest message is going to be for everyone.
Great, thanks, Skye. And we might now go to the Q&A if we could. And the first question is for Ben, and it's a bit of a critique of what we presented today, Ben, because we do know, of course, that one of the groups in Australia who are overrepresented in HIV statistics is Indigenous Australians. Do you think we could use this methodology somehow to shed some light on the epidemic among our First Nations peoples?
Yeah, I think we would have to have a real deep dive into what's available within those sources. So maybe not within these data sources, but there may be other ways that we can do that. So there already is that extra surveillance report that's done every year on this area. That was one of the reasons why we didn't super focus on that here. We do absolutely understand this is an issue in MSM as well. But when we do have one graph in the report looking at this, and the problem is that when you look at the numbers, they're just too small to be able to do anything with. It's just everything bounces around too much. There's no smoothness to any of the curves. You can't really do any really detailed analysis. So that's within the HIV surveillance data, but also within something like the GCPS, which we do actually get a pretty good proportion of ATSI people in the GCPS every year. The problem being it's just the overall numbers are so small, you can't do many crosstabs or anything like that. So I'm not an expert on this area. I don't know if there are other data sources out there that may be more appropriate. And I think Skye's probably the one that would know most about whether there's other things out there that we could do these kinds of deep dives into, which I think is absolutely needed.
Do you want me to add to that, Andrew?
Why not?
Sure. So there are, of course, other data sources, and as Ben has highlighted, the numbers are small, which is, concerns with identification and disclosure, obviously, which we want to always avoid. But there is James Ward, who many of you, probably all of you will know, has set up a sentinel surveillance network that will also add invaluable data to this. And there's also been a national data linkage, so linking HIV notifications to MBS, PBS, and a number of other national data sources, which again will provide far greater detail than we can get from the existing data we have. So yes, there are new data sources emerging that will be useful for answering questions related to Aboriginal and Torres Strait Islander population, keeping in mind the small numbers.
Great. Thanks, Skye. And a question from Daniel. The point is that the point has already been made that some of these groups of interest are really quite small or difficult to reach. So the question is, has there been an effort to systematically review qualitative research in this field? But perhaps at the same time, Ben, I might ask you on some of the qualitative research that's coming out of this research. Yeah,
thanks, Andrew. So the answer to the actual question is no, there hasn't been anything super systematic in terms of looking at everything that's ever been published. There is quite a bit of it though, because as you sort of pointed out from that question, because these groups are small and very difficult to access, qualitative research is one of the easiest ways to kind of get some data from these populations without trying to be perfectly generalizable and perfectly representative. And it means you can actually access some of these populations with a relatively small number of individuals, but then pull out really important insights and themes. So we do know in the past there has been quite a lot of qualitative literature on this in various groups from around Australia. And then there's also some work that we've been doing too. So an adjunct to this GAPS report, which was all quantitative, we also ran a qualitative interview study with overseas born, newly diagnosed men from non-English speaking countries. And we recruited about 24 men and we are very close to releasing the public facing report on that data. And it's really, really interesting. It really reinforces everything I've said in this presentation. Stigma, stigma, stigma. Stigma just comes up all the way through those 24 interviews. And we know from other data sources, really, really recent work that's been going on in Melbourne, coming out of Melbourne Sexual Health as well, where they did interviews of just newly arrived Asian born men. It's the same thing. It's all these issues of stigma coming up over and over again. In Melbourne, they're also doing a current study on PrEP, looking at interviewing overseas-born men about their experiences of PrEP specifically. So that's going to be another really great source. So a lot of this work is happening, but as yet there hasn't been a sort of systematic review of all of it. Thanks.
Thanks, Ben, and it is good to see in the new New South Wales strategy a direct focus on stigma as it affects access to HIV testing, treatment and prevention services. And I think that is clearly an absolutely critical part of the response from now. I've only got a few minutes left, just looking at the top ranked questions. This is an interesting one from Fran in terms of improving prevention based on the data you've seen. Do we aim to increase connection to the inner city gay community where things are going so well, or are we hoping to extend prevention beyond the inner city gay area?
Darryl, do you want to have a go at that?
Maybe.
Well, Ben, would you like to kick off?
Well, I would say, look, we need to be careful in this area. There was some critique of early gay responses sometimes of talking about the kind of gay colonization that you're trying to turn everybody into these little gay robots that live in Darlinghurst. I respect that critique. I think that a lot of the best work in Australia has been peer-based, and I think we should continue that, and we should continue to expand on the word peer, interpret the word peer in new and different ways so that we get access to these people. And that really is about bringing people into peer-based and networks of other men who might be able to share information with each other and so on. Having said that, we absolutely also need ways to address these issues in those men who are never going to be that connected to the gay community. There are a lot of gay and bisexual identified men that don't feel a strong connection to the gay community. And we need a way, as Darryl was talking before about testing, to make sure that those men still feel that they can access services easily and appropriately. We absolutely need both, in my opinion.
Ben, that was so beautifully done. Well, you're welcome back in the community sector any day. We forgive you. No, I really can't add much to that. I think it's a really tricky question that Fran has asked because, in a sense, there are resource choices that underpin that question. That both of those strategies building connection to established communities, but also reaching beyond established communities to increase service access, to increase prevention. Both of those are resource choices as well as strategic choices around how you actually might go about doing those things. But I do very much agree with Ben that I think it actually does need to be a bit of both, that neither of those alone will actually meet the kind of needs that this GAPS report actually highlights. And I think pushing in both directions is going to be critical.
Okay, I think we are almost up, but Daniel's keen on making a comment on that question, I think. Daniel.
Thank you. Thank you so much for today. It's been so useful, but I'd just like to share that on this whole cull data issue, we produced an issues paper which examines the issue quite broadly, calling a number of recommendations. Really, one, the fact that we can have all these conversations at our level, but nothing's going to happen until the Australian government actually sets up a high-level national working group to sort it all out. And also we feel that there needs to be some discussion about the usefulness and feasibility of an indicator of race, ethnicity, particularly in the health context. And that's a difficult conversation, but I think it needs to happen. But in terms of next steps, we're hoping to convene a national symposium in conjunction with the AHW and ABS fairly shortly, and they're very supportive, to explore those issues more, to get the key stakeholders together, and hopefully out of that comes support for a call for this working group. And we feel Kirby would be a fantastic contributor to that process. But thank you very much for the opportunity today.
Fantastic. Thanks, Daniel. Unfortunately, we are going to have to finish now. I'm sorry I wasn't able to get to all the questions. I did want to end by giving a big thank you to Ben for a fantastic presentation. It is an amazing report, and I really would recommend those of you who are in the sector, if you're at all interested in this data, it will be there in that report. And I did also want to thank our terrific panel from today, Daniel Coase, Darryl O'Donnell and Skye McGregor. I've noticed that we've had about 50 attendees the whole hour long. Almost nobody's dropped off, which is a testament to the quality of the presenters today. Well done. Thank you all, and see you at a Kirby seminar soon. Bye.
Bye-bye.
Thank you.